Okay, welcome everybody. Thank you for all your hard work over the past weekend. I know this was a sprint and you guys have made it to the finish line. So um, for Grand Hack 2020, we were all divided in 4 tracks: cancer, digital technologies, aging, and access to healthcare and COVID-19. And this track is Track D, access to care during COVID-19. You guys started off on Friday with pitching, problem pitching, and then networking with others and forming teams. And then on Saturday, you've been hacking at the problem and getting feedback from mentors and witnessing everybody iterate on their problems and refining them. And I'm excited to see the final presentations. So when you are presenting, the judges will be evaluating the impact of your problem. Is it a real problem? Is there potential for widespread impact? Does the solution address identified problems? Is it innovative? Is this novel? Is this first to market? Um, is this convincing rationale for why solutions would work? Addresses challenges specific to stakeholders and what they're interested in? Did you hone in on who your stakeholders are? And then the innovative solution also considers the user experience, interface, and service design. The judges will also be considering your business model. Does the plan you put forth work in the field, and is it easily executable? And is it sustainable? And then lastly, we will be seeing your presentation effectiveness and the diversity of the team. Here is an overview of some of the prizes that we will be presenting and awarding to winners of the hackathon. So in track D, we have a first place prize of 1,500, second place of 1,000, and third place of 500. But there are some other special prizes from sponsors, such as InterSystems Across Tracks is looking for a technology challenge winner of 1,000 and runner up for 400. Brigham Health prize for best innovative health to improve lives with opioid use disorder, 1,000. So if your pitch involves helping the opioid epidemic, that will qualify you for that prize, as well as a Path Check Foundation prize of 500, which is exclusive to this track. Here's some of the partners and sponsors who made Grand Hack possible. Normally this is a big event in person. If you've ever had the privilege of attending, it's you get to meet a lot of mentors, you get to meet a lot of participants and learn from them, as well as work diligently as you have virtually to the finish line. And hopefully we are able to host another Grand Hack in person next year. So I'd like you to meet our judges. First, we have Stesha Doku, a board-certified physician and anesthesiologist. And I will allow her to introduce herself.
Hey everyone, good to see everyone out there, and thank you all for participating today. As she mentioned, I'm Stesha Doku. I'm an anesthesiologist based in North Carolina. I'm also a web designer and developer focused primarily on medical devices and medical software. So I'm looking forward to all of you guys' presentations and your ideas. Nice to meet you all.
Next up, we have Olga Kagan.
Well, good afternoon, everyone. I'm Olga Kagan. I'm a registered nurse based out of New York City. I work as an adjunct faculty for a couple of universities here in New York, and also I have my own consulting firm where working with private and the public sector. My expertise is in nursing informatics, administration, and also research and innovation. So I really look forward to hearing your ideas and to a fun afternoon. Thank you.
Thank you, Olga. Next judge is Ellen McGoach.
Hello, my name is Ellen McGeoch. I work for NeuroFlow in sunny Philadelphia. We focus on tech-enabled behavioral health integration, and my focus is on healthcare, health IT, and small business innovation. I'm excited to be here and excited to see what the teams have put together this weekend.
Thank you, Ellen. Next, we have Suzanne Shirley.
Hi, everyone. I'm Susie Shirley. I work with the Veterans Health Administration. I'm the Director of Partnerships and Community Engagement, and we've been an enthusiastic partner of MIT Hacking Medicine now for a couple years. And my role is mainly around working with high-growth startups and engaging in collaborative design, development, testing, and scaling within the VA. So I'm excited to hear what you guys have been working on this weekend. Thank you.
Thanks, Suzanne. And the next judge we have is Jonathan.
Hi, folks. I'm Jonathan Teisch. I'm Chief Medical Information Officer and Director of Product Management at InterSystems, also a co-sponsor of this. My background's in health IT design, global health informatics, and also practicing emergency medicine. I've participated in the MIT hacks for a couple of years. They've always had great ideas. I've also seen a couple of successful companies come out of it. So looking forward to seeing what you have to say today.
Thank you, Jonathan. Okay, so just to give you an overview to the participants of how this is going to work is I am going to allow 3 minutes for the pitch and 2 minutes for Q&A from the judges, and then 1 minute for the judges to input their responses into their own judging criteria forms. Please stop me if you need an extra minute. And for the participants, I will call who's next, and then on the bottom of the slide, it will say who's next following this presentation, so you can get yourselves ready. And then as you're ready for the slide to progress, just say next and I'll move the slide forward. Thank you. So the first team that we're going to hear from is team D24, team Vector. And then up next will be team D43, organizer. So right now we're going to listen to team Vector.
Hi, that's me. My name's Nick. So hi everyone, we're Team Vector. Next. A virus knows no borders. COVID-19 has wreaked havoc on millions of people globally and exposed glaring flaws in an antiquated healthcare system utterly unprepared for what Dr. Anthony Fauci calls an incoming pandemic era. Climate change and unsafe animal practices are accelerating infectious disease transmission. We believe technology can follow a virus like a virus and be better suited to combat growing infectious rates. This can only be done by changing how we convey public healthcare information by democratizing the current model. If you can pull your phone out and check the weather, why can't you do the same for public health data? Next. Enter Vector, a disease-agnostic platform that puts public health data in your pocket. Vector informs public health decision-making, manages infectious disease spread, empowers the public to understand their risks, and predicts and mitigates local outbreaks. As an example of a use case, at the height of the pandemic, I was living in New York and wanted to know the risk if I visited my grandma in Boston. However, there was no way to easily access this information. Vector brings the relevant public health data to your fingertips. Next. Vector will be capturing previously siloed, publicly available data spanning everything from local COVID-19 prevalence to regional and national reporting to build a predictive AI platform that will alert users of infection risk. We will use multi-dimensional, multimodal data sets to make personalized predictions related to public health. We will kickstart our algorithm on publicly available data, and users who provide their information will receive a more targeted risk assessment. Next. There we go. We are planning on having multiple revenue streams while remaining free to use for the user. We plan on having targeted on-app advertisements by giving relevant medical companies access to our health-conscious customer base. We also plan on anonymizing our database and
Hold on, Nick. Sorry, you got muted.
how that happened. I'm sorry. What was the, I can just restart this slide. We are planning on having multiple revenue streams while remaining free to use for the user. We plan on having targeted on-app advertisements by giving relevant medical companies access to our health-conscious customer base. We also plan on anonymizing our data set and working with ad tech companies to better tailor our campaign. We can also license our algorithm and sell its output to larger institutional customers, such as private health insurance companies, pharmaceutical companies, travel agencies, hedge funds, airlines, whoever needs to understand how a dynamic global health situation will impact their industries. Finally, this is a first-to-market idea with no competitors. Next. For our initial release, we plan on focusing on California because of its robust public health database and large population. Releasing in California will help scale nationally and internationally. The global pandemic has heightened public awareness. We plan on capitalizing on this to reach more downloads and draw more attention to other diseases and environmental risks. In California, our beachhead audience will be those at risk, those more health conscious because of COVID, and travelers. Next. Finally, our team already works in infectious disease fields, and we plan on continuing to work on this with Vector. To step back and look at the big picture, we need to remember that COVID-19 is not the only outbreak. The WHO has acknowledged an average of 102 outbreaks per year across the world. These outbreaks affect underserved populations who are at risk of being left out because of our post-COVID healthcare revolution. Access to free personalized risk assessment based on Vector's output will help mitigate many of these new problems from future outbreaks. Download Vector and put public healthcare in your data. And put public health data in your pocket, sorry. Next. And this is our team. I want to thank them for the amazing work, and thank you guys for hosting an amazing hackathon.
Thank you, Team Vector. Great job. So I'm going to open up the floor to judges for questions.
So Nick, this is Jonathan. So what are the top views and what are the top displays that you think people want to see? What is the chief attractant to this, particularly things that you can do that aren't available on public websites?
So if you go to, I think it's slide 3, we did some quick mock-ups of different UIs that we could do. And I think what's important for this is we want to integrate public health risk into already widely used applications or our own applications. So this would be either opening our application, seeing a heat map of infections for COVID and potentially later other diseases by zip code, also seeing how that translates to your travel, and then additionally just seeing what your personal risk profile will be like. So how that works is your risk profile will be displayed as a binary, high risk, low risk. That's kind of medical standard. And for the heat map, we were thinking kind of like a forest fire scale where it's like mild, moderate, very high, severe. The wording of that would probably change, but think of that more half circle type of display. Does that answer your question?
Yes, yeah, for this point, yes.
Perfect.
Hi, it's Olga Kagan here. I do have a question. I was actually interested to know the data that you'll be using that's publicly available for the risk factor. Would that include the morbidity or mortality rates? What are you looking at in terms of your guiding benchmarks?
We would err on the side of more data. So pretty much anything that's publicly available and relevant, we would be using. So mortality, infection rate, recovery rate. And then we would also want to incorporate more environmental factors, well, demographic factors and environmental factors to develop larger correlations, not just for COVID, but for other diseases as well, infectious diseases.
Thank you.
Any last questions from the judges?
What's the funding? How do you support this as a business? How do you see a revenue coming from this?
So initially we were considering public-private fundraising round to work with municipalities and bring on that initial beachhead user base. From there, we were planning on First, working with municipalities that are more susceptible to outbreaks, either from COVID or, as I've mentioned, smaller diseases. Maybe these are municipalities that have not reacted well to outbreaks in the past, so on and so forth, by poor awareness. The specifics would obviously come from market research. But once we have these municipalities, it essentially becomes a positive feedback loop of we get more users, we get more data, we therefore then get more municipalities, get more users, get more data. And from there, then you can start licensing this larger output out to enterprise clients once you have a really robust database.
Okay, thank you everybody for your input. I'm gonna give you a minute to input your judge form. And while they do that, team D43 organizer, please get ready. Okay, we are going to start with team organizer.
Okay. Yeah. Can I start?
Yes, please go ahead.
All right. Hi everyone. I'm Abhishek, and we are team organizer. Next. As we all know, the sudden outbreak of the coronavirus has left a damaging impact all across the globe. Many countries have resorted to personal protective measures like hand sanitizers to control the spread. However, with an increasing use of these sanitizers, many adverse side effects have also surfaced. Most chemical hand sanitizers contain up to 95% alcohol and many other harmful chemicals. According to a study conducted by CDC, these chemicals have adverse side effects, which include skin irritation, hormonal problems, fertility problems, and have also led to death in some scenarios. Our goal is to tackle this problem. Next. Organic materials like aloe vera, turmeric, neem leaves, and soap berries, when used together, form a natural protective shield and kill microorganisms. Numerous studies have proven the effectiveness of these materials against germs, and they also have shown that they have minimal side effects. We aim to create an all-organic hand sanitizer, which will be as effective as the chemical-based ones in battling germs and bacteria. Next. As you can see, there are many organic hand sanitizers in the market, but the truth of the matter is that they use the word organic as a marketing strategy to lure customers. These sanitizers actually have high percentages of ethanol, which is essentially alcohol, and have very low organic content. As such, they have many of the aforementioned side effects. But Organitizer is different in the sense that it has all the benefits of organic materials and is equally as effective as the rest when it comes to battling germs. Next. As it can be seen, the customer segment we are targeting is the general public. Hospitals and pharmaceutical companies would be our key partners in this endeavor, and our value proposition is that our product is highly effective, cheap, and has minimal side effects. Next. So upon gaining initial funding, the first thing we would do is collaborate with local suppliers to gain the organic materials. And after production of the sanitizers, we would conduct clinical trials to test its effectiveness and gain FDA approval. And after everything has been approved, we would deploy our product to local markets with the help of pharmaceutical companies. Next. Yeah, so finally, this is our team, and we trust that our unique set of skills and experiences would aid us in achieving our vision. Thank you.
Thank you, team organizer. Great job. I'm going to open up the floor to judges.
Hi, thank you for your presentation. Just a quick question. How much do you think this cost would be for your product versus other products on the market?
So a lot of the products on the market like try to use like absurdly high prices because they have the tag organic, right? And they think that that would attract customers. But in reality, these organic materials are actually quite cheap to manufacture. So we trust that our product would be much cheaper than the ones already in the market and would actually stay true to its name that it's actually organic. Yeah.
Hi guys, it's Olga again here. I have a question. I know allergies is a big concern, and when I hear about different foods being used, how do you address any sort of allergies related to products? Because that seems to be, there's a global pandemic too in terms of increased number of people with food allergies and eczema and all kinds of atopic dermatitis, etc., that relate to foods. So I'm just quite curious if you've thought about that.
Yeah, so there would be a few side effects, but the number of side effects which we would have with organizer would be considerably lesser than the ones with the chemical-based ones. So yeah, yeah.
Out of curiosity, just to follow up, do you have any numbers as far as how many people have reactions to the chemical sanitizers out there versus how many are able to or need one that's organic?
I don't have the exact numbers, but it's proven to affect children more adversely than adults. Yeah, I've read that in some reports by the CDC. Yeah.
Any other comments from judges?
Thank you.
Okay, I'm going to allow you to put in your inputs in the judging form. While they do that, next up is Team D30 Cancer Cyst, and after that, Team D65 Emotional Companion.
Just wondering, you'd let us know when we have to start, right?
Yes, I'll let you know. This is going to be a few more moments while the judges finish up their forms.
Sure. Thank you.
All right, we will get started with Team Cancer Cyst. You can begin.
Good afternoon, we're Team 30, and we present to you Cancer Cyst. Next. COVID-19 has had devastating impacts on patients receiving chronic care, such as cancer patients. The reduced immunity makes them more vulnerable, but they cannot afford to discontinue treatment. Raj, a farmer living in an Indian village with liver cancer, used to go to the public city hospital for chemotherapy. However, people have told him that there is a deadly virus in the city and he should not go to the hospital where he could contract it. Now, how will he get the treatment he needs? Next.
Raj isn't alone. About 45% of the Indian population relies on free government healthcare, a system that is currently overwhelmed with COVID patients, as the pandemic is largely being managed by the government sector. So cancer patients who cannot afford private healthcare have to choose between interrupting their treatment or taking their chances with a deadly virus. The rural population suffers more, the mortality rate of cancers being the same as in the urban areas, despite the incidence being half due to inaccess. Next. But what if there were a way to get help at home? Next.
The village healthcare worker tells Raj about Cancer Cyst, an app that is connected to a mobile chemotherapy unit called a Medicar, which goes house to house providing cancer care. Next. She also tells him that the app has resources for knowing more about his disease, his treatment, and counseling. But Raj doesn't understand English and can only read a little. No reason to worry. Cancer Cyst provides video content, has voice support, and offers it in local languages as well. This wouldn't be much different from using his Facebook or WhatsApp. Next. He sets up the app and connects to his doctor, who tells him that the app would keep track of his appointments. The medication prescribed will be available through Medicare itself, given by the healthcare workers, who will also check on his progress. When the Medicare comes, Raj looks inside, and it just looks like a mini hospital on wheels. Next. Raj is delighted that he doesn't have to go to the city while there is a deadly virus around. Next.
Our potential target population is more than 812,000 people. Next. Many patients experience financial difficulties as they prefer private care due to its better service, despite being unable to afford it. A mobile unit would encourage people to use government services, easing their burden. It would also save transportation costs and the cost of moving to cities for treatment. Next.
Our business model revolves around our stakeholders, government bodies and NGOs for financial assistance and setting. Also hospitals which provide healthcare workers, databases and medical supplies. Finally, the patients who lack access to healthcare. Next, we plan to launch within 3 months by obtaining government approval, collaborating with hospitals, modifying the ambulances, training healthcare professionals and testing logistics. Next. We would currently focus on providing chemotherapy during COVID, but in future, we hope to include diagnostic and palliative care. Later, we may involve the private sector and partner with companies such as Uber. International markets may also be targeted later. Next. We did an impact analysis for the top competitors on multiple fronts. No app have all the options we offer and are only affiliated with private sector. Next. Thank you. We welcome all questions.
Thank you, Team Cancer Cyst. I'm going to open up the floor to judges.
என்னால பார்ட்டிசிபேட்டே பண்ண முடியல. இந்த வாட்டி நடக்குது நல்ல எக்ஸாம் அப்ப இந்த போயிட்டு இருக்கு.
I have a question. Can you talk a little bit more about your business model? I saw that there was a fee for patients up front.
I guess I can get us started. So what we plan to do is during the pandemic at least, and the point of this system being in place is to help the ones that are financially disadvantaged. So we wouldn't be charging them during the pandemic. We do potentially in the future, for profit generation, intend to partner with the private healthcare sector because they are also catering to some of the rural areas. And in those scenarios, to potentially generate profitability at that point, we would consider maybe charging a small fee on the installation and maybe taking some commission from the private sector.
So hi, this is Jonathan. Is there any past work from the government or anyone else on mobile cancer treatment units, irrespective of COVID? Has this been an idea that's been floated before, to your knowledge?
So there are cancer detection units in the private sector, but there are no large-scale chemotherapy units, especially in the government sector, because it's a very resource-constrained area. And none of these units that presently exist in the country offer anything more than basic diagnostic testing and some treatment, and they're also limited to a very local area where very wealthy people can afford extremely privatized healthcare.
Hi guys, I do have a question for you. Also coming from clinical background in terms of we've seen many models where care goes to patients, but not to that extent because that is very specialized, and I would imagine it's resource heavy in terms of you have to bring on board, I would say, a physician or registered nurse or somebody who has a very skilled set in order to provide care at home. And two, I'm wondering, usually chemotherapy treatments take a long period of time, so it's not something that takes half an hour. So if the van or the mobile treatment is dispatched to remote areas, so I would imagine travel time, the treatment time. So how many of those can you do per day? And I'm just trying to figure out if you do 2 or 3 per day, if possible, and if you have to commute far distances between those rural areas. So that's one of the questions I have. And the second question I had for you is that the cost, obviously. So I'm just trying to figure out who's paying for it, if it's not the people or the insurance company. So that's this is the, but I love the concept. I think it's wonderful and would be really solving a huge issue. It's just the logistics of it. I'm trying to figure out how that would work.
Right. So the all villages have something called a primary healthcare center, and so these vans, these mobile chemotherapy units that would be affiliated with tertiary government healthcare centers, they would travel to the primary center, where they would be parked for a little while. And villages in India are pretty close connected, so about 4 to 5 villages or maybe more could be covered in one day. So yeah, and for the funding presently, since we're going to be partnering with the government sector, and for now the idea is to break even, we would be looking towards the organizations, cancer donating organizations in India, like the Gates Foundation, and there's the Indian Cancer Foundation of India, Indian Cancer Society, Cancer Patient Aid organization. So they help with cancer care and they help the government with covering the costs of cancer care. So we would look into partner with them.
Wonderful, thank you. And also just keep in mind there are different types of cancer that may require, obviously, a little bit different. There will be different needs among different patients, which some of them will have to be done in patient setting only and may not be done in outpatient setting. So just something to consider.
Thank you.
Great. Thank you, Team Cancer Assist, and thank you, judges, for your insight. I'm going to let you fill out your forms. While they do that, Team D65, Emotional Companion, will be next. And then after that, on deck will be Team D49, Mama on Wheels.
Am I audible?
It's going to be a few moments, yes, but I can hear you.
Yes. Shall we start?
It's just going to be a couple moments.
Okay.
I'll let you know when to begin. Thank you.
Yeah, thank you.
Okay, Team Emotional Companion, you can begin.
Hello all, we are Team Emotional Companion on a mission to fight distress by leveraging artificial visual and speech intelligence. Next slide. We are in 7 months of quarantine since COVID has struck. It has impacted people's well-being and their mental wellness. It has resulted in isolated humans. Next slide. Our approach to Emotional Companion, an all-in-one digital mental health care app that will analyze your emotional state and provide you help in real time right in the palm of your hand. We use facial expressions and speech tone in conjunction with repeated user assessments to analyze the user's emotional state through video chatbot and classify them into categorical and dimensional ways. It listens, talks to the users, and diagnoses disorder using the sentiment analysis and guides them to a proven strategies for improving their mental wellness. It also provides feedback to the users based on their progress and customizes the mental health. Next slide. This is a preview of our prototype where we have a full-fledged profile for the user to track their mental health status. And we also provide custom recommendations and connect them with the suitable health practitioners and providing in-app video chat capabilities. Next slide. We securely encode the user's data and feed that to an audio and visual AI where we will extract the dense features which will be converted to a numerical scale representation. This will be used to provide customized mental health support by suggesting proven strategies and connecting with the suitable therapist. Next slide. So why now? As the data suggests, a recent survey in India proved that there has been increase in PTSD, trouble sleeping, and overall anxiety due to the virus outbreak. Next slide. Our primary consumer base includes patients affected by COVID, industry workers, and healthcare professionals. Statistically, these groups are the most economically and mentally strained people during this epidemic. Next slide. We provide an all-in-one approach that performs real-time emotion recognition using AI input while creating a personal mental health support system for the user. We conduct periodic assessments to attain diverse analysis of the user's well-being. With all the aggregated data, we also provide access to various therapists in the community. Next slide. We differ from the competitors by providing affine representation of both the human facial behaviors and also the voice vocal features, which will be language acoustic. Next slide. Here we have our market size, and our reachable market size will be $11 million. And our business model, our primary users will be from corporate and healthcare. They will be charged a monthly or yearly subscription ranging from basic to premium. We can also partner with health insurance providers and allow users to use our service free of cost. Next slide. So our go-to-market strategy includes marketing through online media and educating people about the technology through tech talks and webinars. So we are a diverse team of developers and medical experts who can make this happen. Finally, we are asking for startup incubators, funding for global scaling, and expanding our solutions to several use cases. Thank you.
Thank you so much. I'm going to open up the floor to judges.
Hey, Seshidoku here. I had a quick question about your setup and your data collection. So how is it that you're going to collect the data specifically, and what types of data? It looks like you had some images of pictures, and also you said some voice analysis. Does someone have to open up the app and then, you know, say, go ahead and analyze me, or how do you do the collection?
So if we take a look at our prototype, wherein in the initial stage, we will be asking the user to come in a video and say hi. So we will be just asking some kind of questionnaire like how is your day and how do you feel. In that particular time, we will be analyzing their facial features and also getting their audio features so as to accurately detect what kind of emotion they are, and in that way we can provide a customized support to them.
And just as a follow-up to that, what do you do as far as private, or at least allowing for privacy for the patient? Do you have anything taken into that account?
Yeah, so since this being a SaaS model, we take a consideration of the GDPR Act, and we will be using the cloud service whoever applies to that particular act. And we also,
yeah. Tell me about what you do with the information as far as therapies. If you can diagnose these things, do you have a plan for offering concrete recommendations or even referrals for help, or do you have what's your effector arm?
Yes. So based on these information, since not everyone will be required for a therapist specifically, so we will be providing programs for them if they don't need a therapist, and we also customize the recommendations based on these. If they are very much critical stage, we definitely recommend them to reach out to the therapists in the community, and then we will help them through that. Did I answer your question?
Yes, fine.
Thank you.
I have a question about, training some of the algorithms that you'll use for the analysis. Do you have, how will you train the algorithms at first to be able to offer that analysis of their voice and facial?
So coming to the algorithms part, in the sense we will be collecting a series of data, not a frame wise. We will be taking a series of frames, and then we will be passing to a long-term work, which will be a time sequence based approach. That will provide us with a classifier which provides what kind of actual emotions that they are projecting through our facial features.
Okay, and just another follow-up. How will you handle situations where somebody might express a kind of an emergency in terms of how they're feeling or what they're experiencing, something that would require or indicate a need for mental health support, right away?
So if we find the the user to be most critical, then we will immediately schedule a therapist to them, so that we are also planning to maintain a profile for therapists also, so that they will also be included in a peer-to-peer support. So that's how we will be able to immediately connect to the therapist once we find them very critical. Thank you.
Great. Thank you, Team Emotional Companion.
Yeah.
I'm going to give the judges a few moments to finish their forms. And next up will be Team D49, Mama on Wheels. And up next after them will be Community for You. Okay, Team Mama on Wheels, you can begin.
Hello, we are Team Mama on Wheels. Next slide. Since the start of the COVID pandemic, next slide please, 1 out of 4 women have skipped their prenatal care appointment, which would entail ultrasound and lab collections. This is a problem as fetal ultrasounds are crucial to monitoring the fetal development and the mother's health. Next slide. So here's the impact in numbers. Next slide. So I bring to you Mama on Wheels. Mama on Wheels is a van service in which we bring over safe and insured prenatal care to the doorsteps of mamas who are concerned about potential COVID contraction on their way to the hospital or have travel restrictions. The van is equipped with an imaging technician and lab technician. Next slide. The van has a bed for ultrasound, a station and refrigerator for blood samples, and a bathroom for urine samples. There's also a screen for real-time telehealth communications with the patient's obstetrician and or radiologist. The van will, of course, be loaded with PPEs, frequently ventilated and thoroughly sanitized. Next slide. The patient's obstetrician books for the Mama on Wheels service on their app. Then, the patient will be able to confirm the schedule and track the van right before their appointment on the patient platform. Next.
This is what a typical visit would look like.
Once the patient makes an appointment at the doctor's office, we would go to the patient destination and begin the telehealth portion of the visit, following which the technician will perform the tests and upload all the data to the electronic health record via a real-time system. Then the patient will have time to discuss any concerns with the doctor before ending the visit. Once the patient leaves, we will perform an in-depth sanitization protocol before heading to the next visit. Next slide, please. We will function from 8 a.m. to 8 p.m. 5 days a week, with each visit lasting about 60 minutes. We will hire the van driver and contract with the technicians from the partnered hospital. In our pilot, we will partner with one hospital in the Boston area, targeting the underserved population in an urban setting. Our goal is to schedule approximately 4 visits per day. Next slide, please. With $400 charged to the hospital per appointment, we project a 20% profit margin in the first year. Once we build our app and van, we will partner with the hospital and launch our pilot program. Once we profit enough to reinvest, we would like to expand in the Northeast region, followed by a nationwide expansion, with the ultimate goal to make prenatal care accessible to the underserved population across the world, during and after the pandemic. Next slide, please. That's Team Mama on Wheels for you. Thank you so much for your time.
Thank you so much. I'm going to open up the floor to judges.
Hi, thank you for solving, in this space. I think this is really important. How will you address the need, that patients and providers both have to maintain their relationship? I know women receiving prenatal care might like to continue their care with the person they're used to seeing. And also the provider may have a desire to really be the one managing the treatment rather than, outsourcing to a contractor for that.
Right. So our model essentially will only perform the tests, but the patient will still be meeting with their own provider and OB for all the follow-up. So the telemedicine part or the telehealth part of the pilot plan will include their own OB. So we just sell our project to the hospital and then everything remains the same otherwise.
Great, thank you.
Okay.
Thank you.
Have you actually discussed some of with Brigham and Women's or anyone there, or is this a theoretical?
It's a theoretical and a hopeful pilot plan.
I was going to say you had a pretty fast 24 hours to get that done on the weekend, but no, I like the combination. Thank you.
Thank you.
That's a great idea, I think, as well. My only concern is how do you offer the service to people who can't pay? Because it sounds like you're charging for it privately as opposed to through insurance, for example. So I'm just wondering if it's only going to be available to a certain segment of population that can afford the service.
Mm-hmm. We will be charging the insurance. So the insurance will take care of everything. That would include Medicare, Medicaid, or any kind of private insurance.
Thank you.
Yeah. Is 4 visits a day enough to do this? Do you think that's sort of the practical limit? I wonder if it's possible to do any more than that. I know you've already sort of done some hand counting.
This was an average. We definitely hope to do more, but just based on the number of patients out of one hospital for now, that's what we think, because we're including the time to get from one destination to another.
Of course.
Also the time to make sure that the van is clean and ready for the next patient.
Good point.
Thank you.
All right, thank you, Team Mama on Wheels.
Thank you.
I'm going to give the judges a few moments to finish their forms, but while they do that, Team D34 Community for You can start getting ready. I'll let you know when you can begin. Okay. And after that will be Team D44 Video.
May I start or should I wait for a little longer?
Sure, you may begin.
Okay. Panels, we are more than proud to present our project Community for You, a personalized assistance to help the elderly regain their autonomy next. In status quo, a lot of countries are enforcing social distancing amid the COVID-19 crisis. As a result, a particular set of elderly living alone are unable to communicate and socialize with others. The impact comes in twofold. One is that they cannot get the help they want in a timely manner. Two, loneliness leads up to bad mental health conditions. Next. These problems we identified is agreement with many research literature which suggests that social distancing can have unwanted devastating consequences on the mental health of the elderly. Next. What we are proposing is a very simple three-button one-stop approach which will allow them to connect with anyone and get any help they want as simple as possible. Next. Our first button is emergency. It will forward your information such as name, address, pre-existing conditions to medical emergency services so that the elderly no longer need to deal with 911 correspondence asking for clarification from them. We memorize all the information for you. The second button is connect. It will allow you to talk to anyone and anywhere in just one button. You can put your family and friends here. We will also be providing some basic hotlines for local community centers. With this app, without this app, if you want to text, you use messengers. And if you want to have a video call, you start a Zoom meeting and send a link. All these are just too complicated for these elderly people. And we will take care of all that for you. You just need to find the person and press the button. Next. The third button is service. This is essentially a virtual community center front desk blog backed by a chatbot. If you want anything, just type it in plain English and we will take care of that for you. I.e., if you have a fever and don't know what to do, the bot will ask you a series of questions and tell you what you should do afterwards based on CDC guidelines so that you don't need to go to the CDC website and check the long passage by yourself. In the event that the chatbot is not enough, we will forward this message to a local social worker center so that you can get assistance by a real human next. Our biggest advantage is simplicity. If something can be done in one app, you should not need to. Our services are not unique, but we uniquely provide a three-button one-stop approach that is simple and accessible for the elderly. You do not need to copy the link or check the numbers or switching between apps. You just need to find what you need and press that very big button next. Our project will be developed on a flexible approach. We will launch a small pilot launch in a small community where we have some sort of connection. And this project will be on a subscription fee-based model, and we expect to have a return on investment in just 3 months. If it's feasible, we will scale it up next. We have a very diverse team and we are fully committed to make this thing happen. We hope we can bring the elderly with more simplicity, more autonomy, less trouble, and less anxiety. Thank you.
Thank you very much. I'm going to open up the floor to judges.
Hi, Sashidoku here. Sorry, I might have missed it. Who did you say was going to pay for this? It's the elderly patients who will pay, or insurance, or who would do that?
Oh yeah, can you go to the business model slide, please? Yes, I think essentially it will be the family who pays this fee, and this would be a monthly subscription fee, and the price match mechanism would be based on different approaches, i.e. we will take care of the local consumption level, and I think a similar possible benchmark would be the Amazon Prime, like the cost of the Amazon Prime membership. I'm pretty sure in most of the cases, a family member would be more than willing to pay for a half of the price of an Amazon membership fee to buy the convenience for their elderly family in need, because this business model is based on necessity rather than opportunity.
Just a thought. I wonder if this is something that I'm just thinking about the elderly people, and you're trying to get people that have sort of mental depression or some alteration, but you're putting a lot of things on an app, which is not necessarily their favorite model. I wonder if this can also connect to sort of a lifeline service, like which is sort of the radio bracelets, or even to an Alexa kind of thing.
Yeah, certainly that can be incorporated, as we also mentioned that we would provide certain hotlines in our functionalities. But based on the research we have read, like a lot of research suggests that there's increased mental health issues are caused by loneliness, and mainly this was a result of like the increased technicalities involved. If you want to hang out virtually with someone, like these elderly people, they are not very like acceptive to the new technology, and that's why a lot of research are suggesting that it is the loneliness that is causing the problem, that is they are no longer be able to just go out and hang out with their neighbors. And we essentially what we are trying to provide offer is a very easy approach for you to like continue to hang out with people which you used to do without dealing with all sorts of like the complications of different softwares, like sending Zoom links or so, which are just too complicated for them.
Hi there. I'm a little, I guess, not clear as to, is this going to be offered to them as an app, or is this something that they dial into? I'm not really sure.
This will be a very simple app. It will be an integrated app, and yeah, and we have show some basic UI design, but I think it can be summarized into a 3-button, one-stop solution. We will like integrate all many features in as simple as possible into this very 3 simple buttons. Like I couldn't imagine anything more simple than this.
Right, it sounds almost like Microsoft Teams that has all the same features. I'm just curious if elderly population, if all of them or what percentage of them would actually be using it or be comfortable using technology to connect, and also, you know, if they have the connectivity to begin with, if they have smartphones or smart technology to begin with. So I'm just curious if you did some research on that.
Yeah, I think we plan to launch our project in a community called San Martin de Porres, is Peru. We have two members in our team from Peru, which are who understand the situation in that community. I think the majority issue with that, I think that community per se is covered with, has a very relatively high smartphone coverage, and the only issue that needs to be solved there is like solitude and loneliness for the elderly people.
Okay, great. Thank you, Team Community for You, and thank you, judges. I'm going to give you a few moments to fill out your forms. While you do that, I'm going to have Team Vitio get ready, and after that will be Team Mimi.
Team Video is Team 44.
Yes.
Sure.
Okay, Team Vitio, you can begin.
Hi, everyone. Next slide, please. Access to healthcare during COVID-19 can be impacted by how good we are at getting patients healthy and home so beds are available for the next person in line. I'm an ICU nurse, and a persistent challenge is that we don't have the tools to make informed decisions about how we can improve our care and stay engaged as a workforce. Next. There's a plethora of patient data in the healthcare system, but a lack of any interface in which clinical leaders can easily compare how staff behavior affects patient outcomes. Next. Our solution is VTO, Visualizing Interventions to Impact Outcomes. This is a data visualization tool for doctors and nurses that integrates qualitative clinical interventions to improve quantitative patient outcomes. In our current state, we have no shortage of graphs, but we're not able to easily see what triggers may have led to changes in these quality indicators. Next. Our planning application works to visualize data to facilitate planning and evaluation. Here's how it works. Next. When bad outcomes occur, our unit educator does a root cause analysis. They can log into our app, upload recent patient data, like infection rates, and then select certain quality improvement projects she's worked with our team to develop. After that, here's what she sees. Next. This graph shows a spike in our infections. Our team got together to list potential causes. When we plug this information into the system, we can easily see that one trigger to infections may have been leadership going on furlough. Our plan then was to implement audits for central line dressing changes, and we'll re-evaluate that intervention over the next few weeks and months. Our platform improves a feedback loop for the entire clinical team. It engages frontline workers, and it has the capacity to look at any variables our team wants to investigate. Next. Our business model includes iteration, marketing, and business-to-business sales. Now, in the future, there are larger opportunities to scale this into a more comprehensive database. However, in these beginning stages, this is a very simple platform to help individual clinical leaders plan, direct, evaluate, and engage their workforce. We can sell it to entire hospitals or individual units within those hospitals. And our next step after these iterations is to pilot them on individual hospital units. So where's the value? This app, next please, thank you. Where's the value? This application helps us improve patient outcomes. Research shows that one bloodstream infection can cost a hospital up to $95,000 per event. Reduction just this one measure alone will save patient lives and hospital money. What I'm trying to say is that our platform will pay for itself once hospital executives and unit managers invest in it. Next. There's a lot more of other details we'd like to talk with you about offline. It's preliminary work, and we look forward to improving access to healthcare during COVID-19. Next. This is our team. We're calling on all collaborators to help us develop this app. Thank you for your time.
Thank you, Team VTO. And nice to hear your perspective from the front lines.
I love the idea. I happen to be a nurse, so I really think it's an excellent idea because we always see nurses as a cost center and never the revenue generation type of profession. And I think that's exactly how you would measure something like this is by the outcomes on the patient's end. So I really believe that you're onto something here. So thank you. Thank you for doing that.
Thank you.
Yeah, I appreciate the potential output, but I'm curious as to what you're doing, because you went through some slides extremely fast. Is this a display of key performance indicators and such as this, and how is this showing metrics not already done by hospital quality departments? I get reports from my hospital every week or so about different things that we're doing like this.
Yeah, so that's actually the point of developing this is healthcare workers in particular are inundated with graphs and charts and metrics. To a frontline worker, they honestly don't mean a whole lot. We'll see the curve on slide 4, that's just a simple bell curve, and it doesn't mean anything. Our goal here is to actually integrate more of that data and take more ownership over it so we can connect the metrics that hospitals are already generating with actual interventions that the nursing team wants to implement. So on slide 7, we see the healthcare infections have increased. We see the blue line above indicates we've maintained our hand washing practices pretty well. We actually have a device that tracks when we hit the hand sanitizer whenever we enter and exit the room. Now, management was suggesting that when we started pulling IV pumps outside of the room, that's why we had these increases in healthcare infections. But what looks more plausible is possibly it's just because leadership went on furloughs and the nursing team lost sight of changing central line dressings when they should be. So it's just a more interactive way to have a communication and discussion with the nursing team so they can actually propose solutions for what we need to do to fix this problem.
Quick question here. Is there any plan to integrate this or see if there's a possibility to integrate with an EHR to also collect data?
So I think that's definitely a possibility. That's a much longer term vision. We can have a more immediate impact right now just by launching a simple platform that has lower investment. But over the longer term, we could absolutely integrate with EHRs and even turn this into more of a database so that we could have more informed decisions across an entire hospital between units or even across hospitals where we're able to say, here's where HAI rates increased, and here's what hospitals actually did and documented in our platform to improve the outcomes.
So it wouldn't be just limited to nurses, right? I'm assuming you're going to be expanding it to. Thank you.
Yes, correct.
Okay, great job, Team VTO. I'm gonna let the judges fill out their forms. And while they do that, I'm gonna ask Team Mimi to get ready. And after that will be Team Dr. Wheels. Okay, Team Mimi, you can begin.
Next slide, please. Meet Carlos. Next, a 24-year-old asthmatic who recently recovered from COVID. He now has some difficulty in breathing and might potentially develop a lung infection. He knows he should perform breathing exercises, but he can't carry around his spirometer every day. Next slide. Like Carlos, almost 24 million people are expected to face the same problem as a complication of COVID. 60% of those with respiratory conditions admit to facing a challenge to perform their breathing exercises. They are stressed out, and this in turn gives rise to many other problems. Next, this has affected the quality of life, the mental health, and the immunity of persons with respiratory conditions. If nothing is done, this is going to affect 24 million people. Next, our solution, We Breathe, improves lung function by providing a virtual snorkeling experience while emphasizing deep breathing techniques. It consists of a VR headset, snorkeling videos overlaid with the sensor data, and a breathing tube with embedded Bluetooth sensor linked to your smartphone, which adds to the gamified experience. Next, why snorkeling? Research has shown that snorkeling improves cardiovascular and pulmonary fitness by promoting deep breathing against resistance. By integrating relaxing audiovisual cues, deep breathing, and active management into a single wearable device, We Breathe provides a gamified, interactive, and relaxing experience. Next, the user wears a VR headset of their choice and then using our breathing tube immerses themselves in a virtual snorkeling experience. After the session is over, the Bluetooth sensor relays information to their smartphone where they'll receive a more detailed description and an AI-powered customized plan on the app. Next, compared to our competitors, We Breathe offers a more personalized, immersive, relaxing, and economical alternative. We are first to market for this kind of product. Next, by improving the lung function, immunity, and promoting mental well-being, We Breathe has a global impact and prevents complications as well as unnecessary hospital visits. Next, We Breathe can also be used post-pandemic to improve treatment compliance in people with COPD, as well as to promote wellness and meditation, resulting in a healthier and more productive population. Next, our focus group consists of COVID survivors, people with respiratory conditions, as well as the general public. By marketing through the internet and social media, as well as traditional healthcare channels and governmental agencies, we aim to commercialize by selling directly through our webpage as well as through our partners. Next. One We Breathe tube costs $20 US to produce and will retail for $30 US. Even with a 1% market capture in the first year, we are projected to make $2.4 million US in profit. Next. Our team's real-world experience of the healthcare system and varied perspectives uniquely positions us to solve this problem. We are a team. Mimi, thank you.
Thank you, Team Mimi. We breathe. I'm going to open up the floor to judges.
Nice idea. I mean, it's sort of. I think of this as an incentive spirometer with adventure videos. You're showing a person wearing a VR helmet right over here. Why would you need that instead of just a screen? I would expect that the helmet adds probably much more to your cost than anything else.
So we're giving them the option of adding on the VR helmet, or if they have one already with them. The VR helmet that we are providing is costs about $10 US, but they have the option of purchasing their own. We can also play this on a screen because the videos are going to be made and played over YouTube.
Are you creating your own video library for that, or are you using existing?
Currently, we're thinking of using existing for the MVP, but we do have plans to create our own videos.
I'm not sure if you'd want to go through YouTube on that, but I understand the concept of the video recording.
I have a question of, is this something that the patient will be given by their doctor, or is this something that they just order off of the internet?
Thank you.
So we would be using a strategy where we sell to both end users as well as hospitals. We are B2B as well as a B2C. We will be approaching hospitals, medical centers, insurance companies, and governmental agencies. So we would look at public and private funding for the same. And if it's done through the hospital or insurance, the cost will be borne by the insurance company or the hospital. If it's the end user, they'll bear the price themselves.
Thank you.
Thank you.
Okay. Thank you, judges, for your inputs. I'm going to let you finish up your forms, and we'll start getting ready with Team Dr. Wheels. And after Team Dr. Wheels will be Team CareShare. And then just as we're all here, just a reminder to put your microphones on mute if you're not presenting or one of the judges. Thank you.
Yeah, can I start?
Sure, go ahead. You can start now.
Okay. Good evening. I'm a doctor. I would like to start with a case scenario about Mahendra, 48-year-old farmer who's suffering from type 2 diabetes since 12 years and does not have an access to proper medical facilities due to his poor socioeconomic status, which has worsened his quality of life. Next. Millions are facing a similar story like him. 70% of population in India account to rural area. Because of fear of COVID, patients with chronic debilitating conditions are not seeking medical attention, and poor compliance can be life-threatening. And because of travel restriction, there's no sufficient supply of medication to periphery. We cannot drop essential medical services and focus solely on COVID. Next slide. We have conducted a pilot survey.
我们这边刷回来，我要上去。
Yang, please mute your. Sorry about that.
We have conducted a pilot survey and we found 6 main problems like poor access to healthcare and poor control of their medical condition. They believe that free delivery of medical services would alleviate their condition. Next slide. So we have planned a mobile care unit which constitute of a mobile clinic and a pharmacy where basic amenities like bed, ECG, BP apparatus, glucometer, pulse oximeter, etc. will be present, and volunteers called health assistant will run a mobile care unit. They are actually mobile lab technician serving as a bridge between patient and doctor through telemedicine, and they dispense free medications under our mobile pharmacy. Next slide. Conditions we are focusing right now are diabetes, hypertension, COPD, postnatal care, etc., which require regular follow-up. In India, medium-sized village has a population ranging between 5,000 to 9,000. So we planned to divide the village into 10 parts and cover subsection of about 800 population each time. A mobile care unit will visit and work for a duration of 3 days in each subsection, and in a month, the whole village will be covered. So we are planning to include 3 villages. So after 3 months, we can get back to follow up with the village that we started delivering services. This is how like regular follow up for 3 months. So already existing government PHC ASHA workers can aid in promoting awareness about us. Next. Okay. The Dr. Wheel web portal is a comprehensive database management system that volunteers can have access to keep a track record of patient record. Next. We plan to establish our project in 3 phases. Phase 1 include mobile OPDs. Phase 2 have advanced facilities and vaccines. Later on with our growth, we plan to include vending machines which have over-counter drugs. Next. Why choose us? We'll be targeting a wider area, reaching peripheral population. We're generating employment. Patient will have unique user ID to keep track of their medical history and follow-up. Next. For us, funding, we'll be targeting big insurance companies like CIPLA, and also try for CSR budgets and government schemes like National Health Insurance Scheme, Prime Minister Jan Dhan Yojana. We already have contacted SIVA, who are ready to collaborate with us. Next. So this is a pictorial representation where a patient with remote access to healthcare service visits mobile care unit. Health assistant examines him, updates doctor via web portal, hands him medication. Next. So this is the team behind Dr. Wheels, bringing a diverse range of skill sets. And yeah, thank you.
Thank you, Dr. Wheel. Great job.
Dr. Bindu, yeah, thank you.
And I'm going to open up the floor to judges.
Yes.
Can you compare this to what itinerant traveling community health workers do? I mean, you're providing, you're purporting to have a great range of services, and I sort of think of that as the province of traveling community health workers. Can you give me a sense of the differences and efficiencies?
Actually, primary health centers right now are not being that functional, and they're now because of the COVID pandemic. I'm a doctor actually. I'm working in PHC. So these due to COVID pandemic, COVID patients are also coming to the primary healthcare center. So just to not mix them up, we were planning to have a mobile care unit just for non-communicable diseases like chronic conditions like diabetes, hypertension, COPD. So initially we'll have a COVID screening where anyone who has symptoms, we'll send them to testing to PHCs, and we want like non-communicable disease patients. Like because of the COVID pandemic, we want to introduce this.
Right. Now I was comparing them to workers who go to patients' homes.
In India, there are because the doctor-patient ratio is very less, so there is no facility where like doctors go to patients' home in peripheries.
I see.
Yeah, and the doctor-patient ratio is like 1:1,800. So yeah,
that's a very striking number.
Quick question. How many units are you guys going to start out with? And then how many actual appointments do you think you can do in a day?
Initially, we are thinking of like 1 unit, like covering 3 villages. So that like normally hypertension, diabetes require every 3-month follow-up, right? So we'll be covering like 800 population. In that population, it'll be like about 40 patients per day. So like in that 800 population, maybe maximum 120 patients in the 3 days coverage area, 120 patients will come up. And so like as I've told you that there are like 9,000, a village constitutes of 9,000 population. So I was thinking of converting, dividing it into 10 and making 800 population, so that every 3 days we give time for one subsection. You got it, right?
I think this is a great solution space. We're hearing a number of teams today that are really exploring the topic of mobile clinics and getting out to communities in rural areas with you know, the medical equipment and providers needed. I would recommend for the teams that are interested in building this out more to do some more discovery and learning from large healthcare systems like KP, you know, Kaiser and the VA, who have fully operational mobile clinics that go out into rural communities, and really learn about, you know, what are the logistics around and the cost around implementing those. But these are great solutions.
Okay, thank you so much.
And Susie, to piggyback on what you recommend, I was thinking about the same thing, because we do have a number of those mobile vans and community services that are being offered throughout the United States. So I'm just wondering if certain geographic areas aren't, obviously certain countries have slightly different variations of that, and just a little more research on that end, I think would go a long way. Thank you.
Thank you so much.
Thank you, Team Dr. Wheels. Next up will be Team CareShare. Let them set up while the judges finish their forms. Okay, Team CareShare, you can begin.
Welcome to CareShare, an Uber-like on-demand app providing helping hands at your fingertips. We connect caregivers with the help they need when they need it. Next. Tens of millions of Americans are members of the sandwich generation who are tasked with caring for their young children as well as their aging parents. They are overwhelmed and they need help. Today, they have to go through a cumbersome agency process, which is expensive and time-consuming. Their problems are only exacerbated by the COVID-19 pandemic and lockdowns. Next. Our user is Anna, a single working mother in Chicago. Anna's neighbor was supposed to help her out today by taking her father to his medical appointment, but she called this morning saying she was sick. Now, Anna must choose between going to work, taking her children to daycare, or escorting her father to his important medical procedure. Next. Meanwhile, Andrea, a certified nursing assistant, is available at home and ready to help. At CareShare, we work to instantly unite them and restore a sense of community. Next. Anna is able to find Andrea through our user-friendly app. When the service is complete, we can use InterSystems Fire API to communicate which health records and insurance companies are applicable. Next. Users are able to select from a wide array of experienced caregivers based on the task requested. They range from basic all the way up to licensed healthcare workers. Next. Next. Our primary customer segments are parents without a regular nanny, or even patients who just need a ride home from surgery. Our secondary customer segment are the care workers who are furloughed, able to help, and would love to get passive cash flow on their days off. Next. During the pandemic, almost 1 million healthcare workers lost their job, and any given day, around 40 million unpaid caregivers are giving value for free, around $500 billion annually. This is an enduring and lasting market potential. Next. We distinguished ourselves from our competitors by providing rapid on-demand matching, and our customers can rest assured knowing that every caregiver is symptom screened and wearing a medical mask and appropriate PPE. Next. Our main revenue stream is a 20% cut in transactions between the user and caregiver. Our prices are transparent, seamless, and devoid of any hidden costs. Next. We anticipate a rapid implementation timeline with an expected market deployment in 2 major metropolitan areas within 6 months. Next. As a healthcare provider, my priorities are the trust and safety of our users. CareShare has a robust credentialing process, including background checking and mask mandates for all of our caregivers. Next. Thank you so much to my talented and diverse teammates and judges for your attention.
Thank you, Team CareShare. I'm gonna open up the floor to judges.
Hi, nice idea. It is how does the you know when I'm getting a driver, I kind of trust that the people know how to drive well. How do I get, if I'm a family caregiver, if I'm one of the customers, how do I get some sense of who it is that I'm matching up? You had a slide, I believe, where you showed different levels of workers that are available.
Yes. So even our basic caregivers need to have at least 6 months of experience with references and background checks. So we know that there's a safety background check at minimum. They have experience, and in the future, we hope to have an in-house certifying agency based on skill sets, or partnering with a third party to credential and verify their skill sets.
Insurance and liabilities of those individuals that you are recommending through your service?
Yes. So right now there are partnerships with third-party companies that provide transportation for patients. I do anesthesia, and I can't tell you how many patients show up to surgery. They've taken the day off work, the family's taken the day off, but we can't get a hold of anyone to come in and pick them up. So without verifying that they have a ride home, we cannot provide anesthesia for them, and the surgery is canceled. And this has implications for the patient, for the care team, for the hospital. There's massive revenue losses everywhere. So if this patient could get an on-demand, I need a ride home, but it's not going to be from an Uber, it's going to be from someone who is a nursing assistant who is driving them, someone with healthcare professionals and credentials that can be verified through the state. So for example, in Illinois, I have easy access to the IDFPR regulations database. So anyone with a license, whether it's a nursing assistant, a medical assistant, a nurse, an LPN, any one of them, I can get their verifications and make sure they have a clean record, and the patient is safely transported home with them under their care.
So they'll be covered under the insurance of that particular provider?
There will, yes. Hopefully there can be an insurance partnership, but our primary mechanism until we can get a customer base will be self-pay and out of pocket.
No, I'm sorry, I apologize. I didn't make myself clear. Insurance in terms of liabilities. For example, you recommend a service and that person, for some reason, causes some sort of injury or something to your client. So how are you insuring that? How are you ensuring that
yes,
you have proper liabilities in place, insurance is in place? Thank you.
We provide liability insurance to cover for any of our caregivers. And if we do have an independently licensed provider who has their own malpractice insurance, we can negotiate a higher fee for their reimbursement for their hourly rates.
I really like this solution as kind of a hybrid of care.com and Uber, where you can find real-time help where you need it, when you need it, on kind of an isolated basis. I think this is really powerful.
Thank you. And I definitely, care.com has 18 million users. At the end of the day, only 340,000 of them end up, utilizing the service and paying for it. Care.com has a lot of issues with the delays. You fill out this questionnaire, you put in your preferences, and they say, we'll get back to you. That could be tomorrow, it could be next week, and you don't know when you're going to get the help. And you're paying a very expensive agency fee. And so, I'm paying a higher rate than I would to a worker, and the workers are getting less of a cut. And it's not really on their time. And we really want these healthcare workers to, take part of the gig economy that they're able to do on their day off even. If you have a day off of your 12-hour shift, but you still want to make a little bit of money on the side, it's great for them and gives them a lot of flexibility and empowerment to be more entrepreneurial.
I love it, yeah.
you.
Okay, for the purposes of time, I think we're going to have to move on to the next presentation. But thank you so much for presenting.
Oh, I appreciate it.
Okay, next up will be Team Immunize.
Hi, can I begin?
Yes, you can begin.
Hi, everyone. We are Team Immunize. Next. In 2019, 21.8 million infants worldwide lacked access to immunization services, and in 2018, approximately 1.5 million children died due to vaccine-preventable diseases. The COVID pandemic has worsened the situation with a 14% drop in childhood vaccination rates. And in the US specifically, there has been up to 60% reduction in rates varying by state. Next. In the United States, the vaccination system is fragmented with decentralized records and varying state and school guidelines. Next. The three key stakeholders involved in childhood vaccination are pediatric patients and family, providers, and the US healthcare system, with the major barriers being low health literacy, logistical delays, and poor record access. Next. So why Immunize? Immunize is a one-stop mobile application that connects low-income families with clinics to receive required vaccinations at no cost. Immunize brings together scheduling, transportation, notification reminders, and education resources. Next. Combining these functions sets us apart from current applications which focus on one specific area and allow maximum resource optimization in an attempt to improve vaccination rates. Next. I'd like to walk you through our app. Pretend I'm Kush, a mother looking for a measles vaccine for her son. I download Immunize and create a profile, which includes his immunization record stored offline. Based on age and prior history, the app will suggest vaccines he needs, list nearby clinics with availability, and help me find affordable transportation. I can also assess education materials and set up future reminders based on the CDC suggested immunization schedule. We have a similar workflow plan for providers as well. Next. In the future, by building strategic partnerships with school districts, state departments of health, and ride-sharing apps, we hope to maximize vaccination rates across the country. Next. Our implementation plan is threefold. Phase 1 is focused on a beta trial in Atlanta, financed primarily through innovation grants. The scale-up phase expands to cover the state of Georgia with funding obtained from the state. Phase 3 includes expansion to other states and broadening the demographic. Capital expansion is leveraged by the addition of private partnerships and advertisements revenue. Next. Our team has rolled out a phase-wise business plan with customer incentives to ensure a quantifiable increase in vaccination coverage, while also providing an overview on return of investment for our investors. Next. The COVID pandemic has adversely impacted childhood vaccination campaigns, especially in the low socioeconomic groups, placing millions of children at risk for vaccine-preventable diseases. Immunize addresses this through a mobile platform, which integrates logistics, notification reminders, and education resources to connect low-income families with clinics to receive required vaccinations. Next. This is our team, and we are open to questions. Thank you.
Thank you, Team Immunize. I'm going to open up the floor to judges.
Thank you. I think you have something very good here, but it was you went quite fast. Can you tell me a little bit more about your business model and maybe in fewer words than are on this screen? Tell me sort of who will be funding this and how you will charge.
Right. Can we move to the next slide, please? All right. Yes, this slide. Thank you. So in terms of the business model, wherein we are beginning, in the first phase of funding will be mainly through the innovation grants. And talking about the phase 1, which is our beta trial phase, wherein our partners would be, I'm so sorry, wherein our partners would be key services like taxi driving apps or the cab services, and wherein in terms of customer incentives, we wish to give this discounted first vaccination booking via Immunize. Now, what in terms of partner benefits, this would be understanding customer attitude and feedback analysis. Now, moving over to the phase 2, which is wherein we launch our product, where And that's wherein we will move ahead to the second phase, that's continued discount over subsequent bookings for follow-up vaccinations to encourage people to use the platform, as well as to encourage them to go ahead with the vaccination. Now, the partner benefits would be increased customer flow, and the return of investment could be 1 to 2% or 2 to 5% return of investment per cap booking, which is done by Immunize. Then moving over to the phase 3, where we plan to roll it out phase-wise to other states. So therein we plan to partner up with various stakeholders, for instance, low stakeholders like groceries and local groceries and pharmacies, and bigger stakeholders like insurance or pharma companies. So in terms of the customer incentives, the discount coupons or codes, a specific discount person after completion of a certain vaccine schedule or routine will motivate the customer or person using our application to follow up or complete the vaccination schedule. In terms of partner benefits, increased customer flow for groceries or pharmacies, and brand visibility and advertisements for insurance or pharma companies. Wherein if I'm talking about the return of investment for local markets like groceries or pharmacies, for instance, our discount coupon provides $5 discount. So for instance, for every N, let's say 10 coupons being used, providing X dollar discount, a return of investment could be an X dollar towards us. And for bigger companies like insurance or pharma, that would begin to 2 to 5% ROI or by using the discount and some kind of advertisement, yeah.
Okay, thank you, Team Immunize.
Just give us an extra minute, Fatima.
Yes, I will. So while the judges fill out their forms, I'm going to have Team Cure Through get ready. And after Team Cure Through will be Project Resilience. We just heard from Team Immunize. D33. Okay, Team Cure Through, you can begin.
Thank you, Fatima. Good afternoon, everyone. Here from Cure Through. Can we please go to the next slide? The problem we seek to solve is the lack of access to basic healthcare needs during the pandemic. Our solution is to provide people with an end-to-end integrated service that gives them quick, safe, and accessible healthcare. In the next slide, we'll talk about Mira. Mira is a single mother in New York City who is one of the 21 million unemployed in the US that lost her insurance when she lost her job in May. With hospitals overflowing and their high out-of-pocket costs, her only option was the safety net hospitals around her. Keeping her and her child's safety in mind, the risk of exposure to COVID in her journey to the hospital, and the waiting room of the clinic, she decided to forego care and stop visits to her PCP. In the next slide, we'll see how Cure Through is helping Mira and millions of others by providing an end-to-end primary care, diagnostics, and transportation service with its pivotal project in New York City.
So to take you guys on Mira's journey as a user, she will start by accessing our platform to schedule an appointment with the drive-through care service and a ride. That ride service will take her to the drive-through facility, which we see as setting up with low infrastructure costs. We see as a tent in low-income communities that will be staffed by local PCPs. So there will be specific lanes and the user will be taken through the car and the PCP will come to the car and perform a brief 10 to 15 minute physical just to assess basic healthcare needs. Our services will also integrate diagnostics if the patient needs to get blood testing or further services. We see this as an amazing opportunity for patients to get access to flu shots and eventually the COVID-19 vaccine in a low-risk way, and then it will end with a ride home. If we can go to the next slide. So our costs will look like an Uber ride, which is optional, and we have capped that at a cost of $20. Our goal is to set this up in local communities so they will never need to travel a distance farther than that. If the user is not getting the Uber ride, it will look like their copay insurance for the physical, and without insurance, we have a base rate adding up to $70. We've reached this price because currently, to get a PCP appointment without insurance, it's about 100 to 160 depending on the range. And we've attributed that PCPs will be able to cut the cost of overhead and administrative costs and just focus on providing the care. If we can go to the next slide. So the revenue streams for our company is from the flat rate drive-in physical, as well as from the primary care physicians who sign up to work with Cure through service. So we see hospitals as well as PCP private offices right now, because of COVID, they're seeing a real decrease in the amount of patients that are coming into their office. And many of these small businesses are facing closing down and losing income. And in terms of the hospitals, after COVID, elective surgeries are going to increase, and they're still going to have PCPs that need to offer these basic health services. So this is an outlet that they can fund and have their physicians come and staff and work here. If we can go to the next slide.
Thank you. We've reached the 3-minute mark.
Okay.
So I'm going to open up the floor to the judges. Thank you.
Yeah.
Hey, quick question. As far as your business model, so do the PCPs have to pay to be able to have access to the patients there or that patient population, or what? Because you said there was no overhead, but they're also a revenue stream. How does that work?
Yeah, so they wouldn't have the overhead costs of running their own office and having to pay for that property. They would have to pay a fee in order to work with us. And we currently have estimated the cost to run a PCP in terms of just insurance and billing per patient is about $20. And then depending on how many patients they see in a day is about 20 to 30. It starts to add up to around $20,000 per month. We've calculated through the initial research we've done that these PCPs have to input just to upkeep their appointments with the patients on more of the admin side. So they would be paying a lower rate to subscribe to our service and be able to furlough those costs.
Are you aware of any examples of drive-through physicals and drive-through examinations, even if we're paying in other ways?
Yeah, so there is one company that we found has created a drive-through service. And currently that model, however, we feel as though it's not accessible to low-income communities. And that's really what we're trying to create, is a low-cost initiative that can use community resources, use PCPs in the community who have the skills to provide this care, and make it more accessible for many community members that don't even seek out this routine care that they should have efficient access to and proper access to.
And what's the difference between doing this where you have the drive-through physical versus providing transportation, but providing transportation to a clinic where the same doctor sees you in a room?
Definitely, yeah. So we came up with this idea of really thinking about what limitations is COVID presenting to these communities right now. These clinics are seeing lower turnout rates of patients showing up because people are concerned with the risk of taking themselves to the doctor's office.
Oh.
If we're focusing on low-income communities, which we're pitching this pilot in New York, they're afraid to get onto the subway. There's a risk to them even walk within New York with the density of the population. So we are pitching this idea that we keep and contain the patients in the vehicle so that the risk is lowered, and then we take them to a site where the PCPs are. Yeah.
So essentially you are eliminating public transportation and having them, but how would you even control a situation with Uber if
yeah.
can't really control who was in Uber before or after them, etc. So would that still add to the comfort level for your clients?
Definitely, yeah. So unfortunately, we again didn't get to touch on the partnership side, but Uber has actually launched Uber Health, and what they're allowing it to do is have patients be sent to clinical appointments. So we're pitching to partner with these services that are existent currently and has established this reputation of people are very comfortable getting into a car with someone they don't know for an Uber to take themselves to a destination. So this combination and partnership, we believe they would feel that sense of security and safety.
Are you also aware of, low-income families typically in New York, they also qualify a lot of times for transportation from some of the companies, health transportation companies.
that are actually covered by insurance, by Medicaid, Medicare, etc. So I'm just curious if you looked into that, and perhaps that could be another place where you can partner with companies that already have, especially many of them have wheelchair accessible vehicles, etc. that clients may need to have accommodations for.
Definitely, yeah. We'd love to look more into that. And as we've kind of modeled out, we don't see that everyone needs to also book the Uber. That's just an additional service that's there for people who maybe don't have access to a vehicle or don't have access to these means of transportation. But it still is a drive-through facility that if they have another way to get there, it is accessible to them.
Also, to touch on that point, so I'm also part of Care Through.
Sorry, guys, I have to cut you off. Sorry, we're over our time with the judges, but I will open. I will let them finish up their forms, and I will let the next team get ready. Thank you.
Thank you.
So, Project Resilience, please start to get ready. We'll start momentarily, and after Team Resilience, it will be dermatography. Thank you.
Hi, everybody. Can I start?
Sure. You can begin now.
Okay. Hi, everybody. We are Team Resilience. Next slide, please. In the event of COVID-19, 66% of employed Americans switched to working online, and these are millions of people. I want you to think about how their routine changed. A working American used to wake up, drive to work, randomly meet some coworkers in the corridor, office kitchen, then answer a couple of calls or emails, and then having a lunch with a colleague or manager again. Now, average American wakes up, puts on a t-shirt, and sits in front of Zoom calls all day. The routine has changed. Importantly, COVID-19 eliminated those social micro-interactions in the workplace that played an important role in sustaining mental health. Next slide, please. Research shows that there is a direct connection between mental health and productivity worth billions of dollars. We aim to recreate those vital interactive parts that went missing with COVID-19, and with that address productivity issue and key HR KPIs. With that, I pass it over to Kevin to talk about the solution.
Next slide, please. Project Resilience is a web-based platform that creates space for social and purposeful workplace interactions virtually. We match employees with each other for these micro-interactions throughout the week. These can be social, mentorship-based, or more group team-building activities, and they can be unstructured or facilitated through our platform. Next slide, please. The way that this would work is that employees would be sent an invitation over email where they can opt in to have a social or purposeful interaction that week. They can also provide specific schedule availabilities or have these pulled from a calendar app related to the email. We leverage emails and existing means of communication such that users do not have to download another app or maintain a separate website login. Next slide, please. If they accept the invitation, they'll be matched with somebody else with similar interests and availability and receive a confirmation email with an access link. Clicking the link in the confirmation email will take participants to our platform where employees can engage with each other in a time-limited, structured or unstructured video session. Next slide, please. Depending on the type of engagement, for example, social, mentorship, or team building, there may be different options for activities that they can do together that are more fun or more work-related. Next slide, please. Some Slack plugins have aimed to recreate these office interactions, but companies that do not subscribe to Slack would be excluded from this group. And other professional social platforms are geared more towards external networking rather than team building and culture building within a company. And neither group have really significant mechanics for these facilitated interactions or team building. Next slide, please. We plan to sell directly to companies with a freemium subscription model and also partner with benefit distributors as channels for increasing our reach. Next slide, please. We have a diverse team with backgrounds in business, healthcare, mental health advocacy, and design, and also lived experience working remotely during the new COVID pandemic. So thank you for your attention, and we welcome any questions.
Thank you. Opening up the floor to judges.
What matrix do you use to match people?
Sorry, say that again.
What matrix would you use to match people?
So the matching mechanism is primarily based on the type of interaction that they identify in that weekly invitation email. So if somebody identifies they're looking for a social interaction, we would match them with somebody who is also looking for a social interaction and has availability that's similar to what's reported in the invitation.
And
so do you collect data? You collect some personal data of individuals in order to match them, I would imagine?
It's purely based off of the email that's, so on the back end, if a company subscribes to our service, they would provide us with a list of sort of email participants, if you will. So we would have data mainly on sort of which email address was affiliated with which tags, if you will, or interest for that week, and perhaps the prior match history, but we wouldn't necessarily have users actively maintain their own profiles, so to speak.
Out of curiosity, how are you guys going to maintain this product after people go back to the office? How are you going to evolve?
Yeah, so I think many workplaces have expressed that for the foreseeable future, they may be living in this virtual work environment or providing people with the flexibility to do that. So our target demographic is largely virtual predominant workforces. For somebody who has regained those office space experiences, there may not be as much of a need, although there are, the market has proven that for some of those Slack plugins that I mentioned, for example, even companies that are office based might be interested in using this as a way to increase sort of inter-department or interpersonal communication and team building within the companies, even when they're in a physical location.
Can I add a couple of cents here? Sorry.
Sure, go ahead.
Yeah, I just wanted to add that we did some research and we figured out that a lot of workspaces would not be back after COVID in the same capacity as they were, and some of them are closing permanently. So we still have a pretty large base for development after COVID. Sorry about interrupting.
Yeah. Do you see this as going after teams that already interact, or in other words, like smaller work teams, or do you see this as finding people that don't normally interact with each other, like across a large company?
So I think our target is for mid and large tier, like large employee companies that have a large team-based element. If you have, a small business that, is super small and everybody already interacts with each other, there's perhaps not as much of a need for this. Or if you have a work environment that isn't necessarily team-based, or there isn't additional kind of benefit to having departments interact with each other, then it may not be as salient. So it's more for companies that know that they want to promote team-based culture or sort of inter-company networking.
Thank you so much. I think that's just about how much time we have for Q&A, and we'll be moving on to the next presentation.
Thank you.
Thank you.
Okay, team dermatography.
Hi, can you hear me okay?
Yes.
Perfect. Let me know whenever you want. Would you like me to go ahead and start?
Just a minute. What is the next stream? Which is can you please go back to the previous slide? D6 stream.
So next up after dermatography will be D16 Jocelyn. And dermatography, you can begin now.
Great. We are dermatography. Next. This is Gertie and Constance. I'm a dermatologist, and they represent my actual patients. They have comorbidities that put them at increased risk of morbidity and mortality from COVID-19. They are both concerned about a new skin lesion, but don't want to see a dermatologist because they are scared to go out during the pandemic. Also, the wait to see a dermatologist in person has become several months long due to the pandemic. They're offered telemedicine, but they cannot figure out how to operate the video platform. They try to send in photos, but these are the photos they send. I can't make a diagnosis based on these poor quality photos, and I get this all the time. A 2013 study showed 1/4 of Americans consulted a healthcare provider for skin problems. We all know that telemedicine usage has increased significantly since the pandemic. One study found a 42% increase in telemedicine usage in 2020. Unfortunately, technologically challenged people like Gertie and Constance are not able to utilize this important tool. Next. The simple solution is our company. dermatography. We send out a dermatographer that is a trained technician that will come to your house and set up and take care of the entire televisit for you, including getting high quality images. Next. We will start with dermatology and then expand to other specialties. We will start by selling to telehealth platforms as an add-on service, then expand to large healthcare systems and physician practices, particularly those who treat older patient populations that are at increased risk during the pandemic, followed by practices that care for a large number of immunocompromised patients and patients that face technological barriers. Next. Everyone wins. Insurance companies save money, telehealth platforms, of which there seems to be a new one popping up every day, get more customers. We create new rewarding jobs for our dermatographers. Patients gain access to board certified physicians, and those physicians can confidently provide necessary care. Also, families know their loved ones are getting the care they need during this scary time of the pandemic and beyond. Next. So in Gertie and Constance's case, I, the dermatologist, see these high quality photos that the dermatographer sends me and quickly decide Gertie's lesion is completely benign. She has nothing to worry about, but Constance needs to come in. We catch Constance's melanoma early and easily remove it in the office before it metastasizes, therefore saving her life and saving the system lots of money. The average cost of caring for metastatic melanoma is over $400,000 per one patient per year. In our case, we saved Constance's life and saved the system over $400,000 by catching her melanoma early through the use of dermatography. Next. And this is our international all-star team. We wanted to thank the organizers very much for this event. We all had a lot of fun working together and we learned a ton. So thank you all.
Thank you, Team Dermatography. I'm going to open up the floor to judges.
Also, a quick heads up that I'll set the timer on my end so that you guys will be notified as well when 2 minutes is up.
I have a question about the dermatographer. So that's not a dermatologist, just a person that comes to your house to take pictures, basically. Right?
Exactly.
Yes, and just to add on to that, so for our pilot phase, we're thinking of having already HIPAA trained community health workers, social workers, and then we would train them on the imaging. But as we expand outward, we're looking to train other people as well to do the imaging and become HIPAA trained.
Thanks.
I was about to suggest perhaps you can tap into professional photographers for probably minimum without jobs at the moment. To do that, it's a lot cheaper than hiring, let's say, an RN or a social worker. But just a thought. Thank you.
Any other comments from judges?
I like Olga's comment about leveraging, photographers who do freelance work, for this kind of thing. And then, but in another direction, would it be helpful to engage providers who not only, or people that can not only take the images, but also perform a biopsy?
That would be a little cost prohibitive because you need a little bit more training and depending on, rules and regulations, you can't just have anyone do that. Mm-hmm. But this is a triage tool, right? Those few patients that need to come in for the biopsy, we bring in, but we can take care of so many more patients that don't need to come in and they're not taking up those clinic visits, those valuable clinic visits for people that really need to be seen urgently in the clinic, which is what's happening now, especially with the pandemic. The wait times are becoming so long. We are getting delays in diagnoses, delays in treating these poor folks.
That's great.
How quickly can you dispatch a person like this to go to take the picture?
How quickly?
Do you dispatch people, right, to come out to the location to do this?
Yeah, immediately. But we would have a little bit of time to set it up, just like any visit, any doctor's visit. You set it up in advance. If it's something emergent that we need to get someone out immediately, we can do that.
Yeah. Oh, please finish your thought, and then we'll have to move on.
Yeah. So hopefully that answered the question.
Thank you, Team Dermatography.
Thank you.
Okay, Team D16 Jocelyn, please get ready. And after Team Jocelyn, it will be Team D35. M. Shiketsa. Sorry if I butchered that. Okay.
I'm ready.
So, do consult, please go ahead.
Yes, I'm
I
ready.
thought we were seeing Jocelyn.
Actually, it's called to consult.
Yeah, I think it's an error in the naming.
Okay.
So the team name is Do Consult, but it's
But it-
number D16.
Okay.
Thank you.
Good afternoon.
Go ahead.
Good afternoon. We're here today to talk to you all about our solution to consult. But first, I'd like to share the story of my uncle Jose. Next. He's a 45-year-old resident in Lima, Peru. He suffers from diabetes and has chronic complications. And because of the pandemic, he's unable to get his medications and attend his monthly appointments in the hospital. Next. As Jose, many people are in the same situation. Every year, chronic diseases represent 71% of all deaths, especially if untreated. Now imagine being confined with fear of going to hospitals and healthcare systems disrupted. Patients with chronic diseases are being neglected as access to healthcare is now worsened by the pandemic. Next. So to narrow down the problem, our first target is Peru, one of the most affected countries due to COVID-19. With thousands of cases rising each day, the health system collapsed and access to healthcare became more limited. Next. In response to these problems, we present To Consult, a platform that offers virtual first patient assessments to treat chronic diseases and make sure only the appropriate cases will go to hospitals. First, the patient will create a profile. By answering a questionnaire, we generate a medical history, which will easily be available to the medical team. Next. They'll be able then to schedule appointments with doctors and take a screening test. In addition, it'll offer reminders to help patients stay on track with their treatments. Next. So telehealth is not well integrated into healthcare systems in Peru. But in this way, the consult approach enables anyone with a smartphone to connect with physicians in a safe and timely manner. Next. Medical students will be in charge of the first virtual assessment, under supervision of a licensed physician, of course. We'll partner with universities and healthcare facilities where the in-person appointments will take place if needed. Next. We'll offer 3 months of free user access to appointments and a monthly fee of $10 with unlimited access after the free trial. And this is 50% cheaper to the current market fee. And based on the rate of smartphone and telemedicine users, we consider a net of 850 users a year, reaching our payback period in 2 years. Next. So to summarize, the consult is differentiated for 5 key reasons. First, it increases accessibility while using medical resources efficiently, so to reduce the strain put in the healthcare systems. It'll ensure patient engagement with our treatment tracking system and will empower medical students as well. Finally, we're demonstrating feasibility with our revenue streams and it's scalable to other countries. Next. With the consult, Uncle Jose and many more patients will get the care that they need. So let's make this happen. Thank you.
Thank you, team Do Consult. The floor is opening up to judges.
So is there intelligence applied to the patient screening application? I didn't quite catch that. It appears that you ask the patient screening questions, but then what happens to the answers?
So if we can go to the application.
Yeah, after I present, after I answer them, what happens?
Yeah, so they will get a first appointment with a physician or a medical student, and so they will evaluate if they really need an in-person appointment in the hospital with a specialized doctor. So in that case, if there's a specialist needed, they will just direct and recommend to other specialists from other hospitals. But but mainly the doctors will do a first assessment to these patients.
So the point of the app is just to give initial information to the medical students? I'm a little confused, I'm sorry.
No, so the students are medical students, and they will help to do these first assessments.
I see.
Yeah, they will do these first assessments, and they will try to come with a treatment to the patient in case this is possible at home. But if not, if they need a specialized doctor, they will recommend them to another in-person appointment.
I see.
Any other comments from judges? We have time for one more.
I have one quick question. So the kind of information that you'd be asking patients to put into the app, or some of those questions and answers are deeply personal. How would you address the trust factor there with people putting that information in?
Well, we'll create thorough policies and confidentiality agreements with patients, making sure all the information is stored in a secure system. And only the patient and the authorized physician will have access to this medical history and personal record.
Thank you.
Thank you. Okay, next up is Team D35, M. Chikitsa, and after that will be Team D54, Oxygen for Life. So Team D35, please get ready.
Yeah, am I audible?
Yes.
Yes.
Shall I start?
Yes.
Hello, everyone.
Sure, go ahead.
Our product is Telemed, a platform that uses technology to provide free and accurate healthcare from a distance. Next. Due to the COVID-19 pandemic, people have grown reluctant to visit healthcare facilities. In such a situation, telemedicine could be really helpful. Although stats indicate the rise of telemedicine, it has certain drawbacks that need to be addressed. To better understand the drawbacks, we'll walk you through Zara's story. Meet Zara, a 35-year-old woman living in a tier 2 city in India. She lives with a husband and 10-year-old son and is currently the sole provider of a family. Next. Her son has been suffering from left ear pain with a discharge for the past 2 months. She does not have the time or income to take a child to the clinic, and as such, she attempted to use a telemedicine platform popular in the city. Through video, her child was incorrectly diagnosed and was treated twice for the problem. Next. Zara is one among half the world's population with inadequate access to healthcare worldwide and could be one of the 100 million people in the world who would be pushed into poverty due to medical bills. Next. A friend of hers recommended our new telemedicine platform, Telemed, as it is free, more efficient, and more accurate than existing telemedicine platforms. She likes the idea of using technology to make accurate diagnosis without having to go to a hospital. Next. She registers a profile for her son with a unique ID. His vitals are taken, and she puts her son's medical history into the application, and the doctor requests otoscopy. The request is registered, and a mobile clinic is dispatched. Within a few hours, the mobile clinic arrives, and she takes her son to be tested. The otoscopy images are sent to the doctor via smartphone, and he or she accurately diagnoses the problem, and the correct treatment is started. Next. The mobile clinic has access to various clinical examination adjuncts depending on various clinical scenarios like ENT, skin, blood glucose, etc. Had the patient presented with a skin rash, the mobile clinic would have had access to a high-resolution magnification attachment to capture images of the rash. Next. Looking at the business model, we opted for a non-profit organization. To cover our cost, we'll be targeting government healthcare projects mainly, particularly grants from government public healthcare schemes, international organizations, local CSR funds, and voluntary donations too for the service use. We also aim to procure various different medical equipment through donations from startups wanting to get their medical devices out. Other options include advertisements on a mobile clinics, which is roughly between 500 to 2000 USD depending on the size of the mobile clinic. Next. A few of our focus areas include free healthcare access to all, anonymous central EHR system for research, reduced diagnosis times, and better efficiency for doctors. We offer something that no one is currently offering collectively, that is objective vital data collection and smartphone-enabled diagnosis via mobile clinics for telemedicine. Next. This is a diverse team consisting of doctors, engineers, UI, UX developers, and market analysts. Thank you.
Thank you so much. I'm going to open up the floor to the judges.
I have a question about, I guess, how is this different than just a normal, like your health insurance comes with a telemedicine app that connects you to your doctors? Like, how is this different than that?
So with this app, we're having the diagnostic tools such as these that are going to be attached to the phones, and they're available via mobile clinics, which is not available through insurance-based telemedicine apps. And in countries like India, for instance, often the telemedicine platforms that are available currently, they are not through insurance or hospitals. They are private pay, and most of the people cannot afford the cost. Our platform is 100% free to the consumer. Anybody else want to add to this in the team?
Yes, so I'm a doctor, and most of the time when you see a patient, you need their vital data, such as their pulse, respiratory rate, and blood pressure to accurately diagnose the severity of their condition and treat them. And our app is one that does this through the smartphone, whereas normal telemedicine apps don't usually do this.
Thank you.
I would like to just mention, I don't know if you're aware, if you did some research to see apps that are already on the market that actually do some vital signs that could be accomplished without necessarily some of the gadgets that you are offering here. I don't know if they're available in India necessarily, but I just wanted to know if you did some research that it maybe perhaps can find some of those that are already existing that you can integrate.
So we just have a table about listing the different competitors, and if you look at it, some do actually have the vital signs. Those apps are usually more costly than the regular telemedicine apps. The second thing is vital signs help to triage a patient, but certain things such as ear infections, skin lesions, they need more specialized equipment to accurately make a diagnosis. So vital data is good, it helps us triage patients, but it's not the only thing needed to make an accurate diagnosis.
Also, we aim to be, yes, as I said, much more accurate because the existing apps don't provide the accuracy we're aiming for.
No, I agree with you. It's just that if you already have a mobile van that provides those attachments to take vital signs, is there also a physician on that mobile van? I'm just not following exactly. The mobile van is there just to provide the attachments for the vital signs and the images to be taken and then remotely then communicated to the provider to make the diagnosis? So the minivan is sort of like the in-between?
Yes. So the idea is to minimize the time that doctors spend per patient. So the vital signs are recorded and the history is sent to the doctor. He or she then decides whether the patient needs the adjunct. The clinic dispatches a vehicle and the devices are taken, images, for example, if that's what or urine dipstick, and the results are sent to the doctor. And if he's able to make a diagnosis just based on the clinical, the history, the vitals, and the adjuncts, then that saves a lot of time.
But as we scale up, we get more.
Sorry, I have to cut you
want
off.
to have healthcare staff.
35. Thank you for answering all the questions from the judges. We're going to move on. We're going to let the judges complete their forms. And we have Team Oxygen for Life up next. And after that, Team D50 SIPI. And I'm going to let you prepare for just a moment while the judges finish their forms.
Yeah, can you hear me?
Yes.
Shall I start?
Just one moment. I'm going to let the judges complete their forms from the prior team, and then we'll get started in just a moment. Thank you. Okay, you may begin.
Yeah. So OxyReach is a digital platform to ease hospitals alerting oxygen manufacturers when nearing a crisis, thereby predicting an emergent need. Next slide, please. So in India, the problem is that in spite of increasing production of oxygen, number of patients dying due to oxygen insufficiency is actually increasing. So actually the problem here lies is that there is no any existing prediction model for industries to help them wrap up production. So for example, normally what happens is that hospital, or in case of increase in cases, hospital takes 2 to 3 weeks to actually order the industry to increase to actually supply them oxygen, and industry take their own time. So this is a complete delay system for supplying the oxygen to the patients, and until the oxygen is supplied, the patients have already died. Next slide please. So the statistics state that the oxygen need in India has actually increased to a very rapid amount. So now there are 20% of the patients, according to WHO data in India, which actually which are in dire need of oxygen. Next slide, please. So the solution we are working here is that to reduce the delay, what we are doing, we will be connecting the weekly updates of the database, and according to the detection of the increasing trend or spike in the cases, we will send out notifications to the industries to ramp up the production. So next thing, what we are going to do is to establish link between companies and hospitals to meet their needs. Next slide, please. So actually, in case if a regional industry, because there are some states in India which actually do not have their own suppliers of oxygen, so they transport oxygen from other states. So in case the threshold, we have the data about the threshold of the industries, the oxygen they supply to the required hospitals. So actually, if the hospitals are out of stock, so they will be indicated red, and from those hospitals, automatically the app will send the notifications to the industries which are in the green region. So green regions means industries in those regions where COVID cases are low, but they have adequate oxygen supply. So these green region industries can contact the hospitals through this app. So the hospitals through the app can actually, again, through this app, to the location and all, it can actually track the nearest oxygen supplier. Next slide, please. So this is the color coding system we are using here. Next slide, please. So our target market, so basically industries are benefited in this because we are easing out the supply for them. We are actually providing them with logistics and prediction model, which will help them provide robust supply to deal with any case surge, and hospitals are benefited because patients' lives are being saved. Next slide, please. So this is the prototype for the app. Next slide, please. So here we can see the hospitals indicated in red means they are out of stock of oxygen, and hospitals indicated in green means they have adequate oxygen supply. Next slide, please. So
All right,
this is the portal
the
for
time limit of the 3-minute mark. Thank you for sharing. I am going to open up the floor to judges now. Thank you.
Very nice. Is there already a chain of communication to oxygen suppliers and to hospitals to get this information? Is there currently a way of particularly for the suppliers, is there any kind of standard channel for reporting their supplies?
So in
Hi,
the existing, yeah.
So what happens in India is that we have an existing system of a supply chain where when a hospital, linking between the hospital and the supply industries already exist. But what we don't have is a prediction model that can actually tell you when we're reaching an out of stock crisis. So that has been our main motive. Our plan has not been to form a supply chain because I believe a lot of that, uh, I wouldn't say a lot exists in the Indian healthcare system, but if we could somehow ramp up the production to meet a crisis, I think that would serve the purpose.
Yeah, and the basic thing we are doing here is that through linking is those regions which actually don't have oxygen. So we are linking them to the industries of the other region. Otherwise, it is a very tedious task in India to reach out to the industries in other regions. And there is no existing portal for linking hospitals and the industries throughout the country.
Thank you so much. I'm going to give a moment to the judges to complete their forms. Okay. So as they prepare, we have one more presentation, Group D50, SIPI, and I will give you a moment to prepare. I'll let judges finish their forms.
Am I audible?
Yes, you are.
Thank you.
Okay, you may begin.
Thank you. Hi, good evening, everyone. This is Dr. Santosh, and this is my expert mentor, Dr. Soundarya. We are from the team SIPI, where SIP and PP, where every life counts. Next slide, please. So I'm a pediatric resident, where since the time of COVID pandemic, I've been spending 6 to 12 hours in COVID and ICU shifts, which eventually, when I start my work within 1 to 2 hours, it leads to profuse sweating, exhaustion, and dehydration. And I fear that I can jeopardize the care given to the patient. So I feel the need to access to my well-being or health in order to deliver prime care. Next slide, please. So this is the solution, which is simple and effective, that is add on to the currently used model of PPE. Requirements being the PPE per se, IV drip set, and the milkshake tetra pack of water fruit juice to sip in. So here, the fruit juice is attached at the level of the waist. The zipper, the IV drip set is pierced, and it is along the zipper, and it comes out to the side on the hoodie. And I just insert it into the mouth, angle of mouth through the N95 mask, and I don it as usual. Next slide, please. Next slide. Next slide. So what technology is involved? There is none involved. It's just an effort from the frontline workers end. Next slide, please. So this is a survey conducted among the residents in the government hospital currently I work in, among the various departments, who feel the need to rehydrate themselves. Next slide, please. So this is the post-implementation survey wherein they have done this modification. Since we are in the government setup, we can use IV drip sets and modify the current PPE. And they felt that they could justify their duty and perform one's duty to satisfaction. And they would recommend this to other healthcare workers to improvise their care. Next slide, please. The end users is the global market, being the district hospitals, secondary and tertiary hospitals, because COVID is a pandemic. Every nook and corner of the world is currently facing the situation. Next slide, please. So the go-to-market strategy is approach the PPE manufacturing companies and incorporate this modification. Hence, it will be a sterile process and there will be no fear of infection. Next slide, please. The steps ahead, it's partnership with companies, final prototyping, seed money or grant leading to product release, which will be ultimately be sustainable, and healthcare worker has access to his or her health and thereby provide the best care during this pandemic and post-pandemic too. Next slide, please. So access to healthcare is improved by empowering ourselves with subtle thoughts and ultimately deliver prime care. Thank you. Signing off from Team SIPI, that is SIP in PPE, where every life counts for us.
Thank you, Team SIPI, and thanks for that demonstration. I'm going to open up the floor to the judges.
Thank you for this. This is a great solution, very simple solution to a pressing problem. I would, if you're open to a suggestion or a recommendation, you may want to try to join the COVID-19 Maker Challenge that's beginning next week for disaster relief solutions hosted by the VA and Challenge America. So I'll put the link in my feedback form if you're interested.
Sure, thank you so much. I'm looking forward to it. Thank you.
That's a great idea too. I'm just thinking about, you said it attaches at the waist, the hydration pouch. So that was interesting to me because I, as a nurse, you know, when you move around and you know, leaning against things and lifting patients, etc., you know, would you consider maybe having multiple attachment points just because, you know, sometimes it may not be necessarily in the location where it's the most convenient, especially by the waist where you're bending a lot and, you know, maybe holding the patient, etc. So trying to see whether you did some usability studies and just to see whether it's the best point of attachment.
Yeah, exactly. It's like, it depends on the comfort. Wherever the people manufacturers can provide, it's a pocket issue. It's a, like, it will be completely closed where the Tetra Pak or the water issue will be fixed, and the entire dripping will be like the company has to take like will partnership. So it's fixed at multiple points. It's stable all throughout, and it comes in at the angle of the mouth inside the identified, providing a complete seal. There's no chance of exposure outside.
I guess what I'm worried about, if you press on it, you know, it doesn't have like a one directional maybe valve or something, so it's not pumping right out. You know, when you squeeze a juice box or something that's similar on a picture, typically, you know, if you press on it, if you lean on something, it will come right out. So I guess you have to avoid that type of spill, right?
It is just like how a Tetra Pak, small Tetra Pak, it sits in you, it comes to your mouth, it goes nowhere else. There's no chance of spillage.
Very interesting idea. Thank you.
Thank you,
so much.
Team SIPI. I'm going to let the judges finish their forms. And that brings our presentations to a conclusion. It's been such a delight to see your initial problem pitches and now the solutions that they've become and how they can be implemented in the real world. Thank you for letting us go along with your journey.